Hello, my name is Eduardo Matta. I am Chief of Body Imaging and Vice Chair of Quality in the Radiology Department at UT, Houston. And I'm here today to talk to you about quality and professionalism. As professionals, it is incumbent on us to provide service that's safe, efficient, and with dignity. That is, our service should be of high quality, but what does it mean to have high quality service as a medical professional? Well, let's start with a sample case. We have a newborn that is suspected of having congenital syphilis. The physician prescribed 150,000 international units of penicillin intramuscularly. Instead, the patient got 1.5 million units and the drug was administered IV instead of IM. Patient expired. Subsequently, 3 nurses were later indicted by a grand jury for negligible homicide. But really, who's at fault here? So first of all, you could think about the physician. When you look at the order, the physician's handwriting is rather poor. You can't really read the numbers. You can't really read the route of administration or the units. And so it was very difficult for the pharmacist to actually see the proper order. How about pharmacy? Should pharmacy have some fault here? So the pharmacist actually consulted the infant's progress notes and the drug reference book to determine what the usual dose is. Unfortunately, the pharmacist misread the dose in both sources as 500,000 units per kilogram, which is a typical adult dose, rather than 50,000 units per kilogram. How about the nurse? So the nurses were concerned about the fact that with such a large dose, they were going to have to give many injections IM. And so they consulted their resources to see if they could give the dose IV, and they erroneously concluded that they could, when in reality they could not. We could also talk about the manufacturer. If you look at the syringe for this particular drug, it says to be given IM. Unfortunately, the letters IM fall right in the plunger, and so they overlap and you can't read the letters very well. So when you're trying to find out whose fault it is, you have to ask yourself if we should really be blaming one person. When you blame a single person, you inhibit open communications, errors are concealed, and you don't learn from the errors or system issues. Also, blaming somebody really focuses on the least manageable element, which is the person. Any one of us, when we make a mistake, we're really trying to do our best, and simply saying, well, you gotta do harder or work harder, do better, doesn't really cut it. What you really should do is thinking about how errors occur. So errors are usually due to system failures, not just an individual action or inaction. To improve quality, we really need to look at our systems. And so this case that I talked about was analyzed by the Institute of Safe Medication Practices, and they found over 30 system errors in the care of this patient. So this case fits very nicely in what's called the Swiss cheese model. For every given event, there should be multiple barriers to prevent errors. However, those barriers are not perfect, so there's holes between them. And so if the event managed to go through all the holes without hitting the cheesy part, then you basically end up with an error or a bad outcome. This focus on errors led to a report by the U.S. Institute of Medicine in November 1999 called "To Err is Human." Basically, this was a meta-analysis that yielded a conclusion that between 44,000 and 98,000 people die yearly as a result of preventable medical errors. That's about 2 to 4% of all U.S. deaths. And in 2013, there was a follow-up study that said the figure was closer to 210 to 400,000 deaths per year. So in any case, this increased awareness of medical errors in the United States. And there was a follow-up report in 2001 called "Crossing the Quality Chasm." This called for changes in the healthcare system to improve quality. It was a more prescriptive than descriptive report, unlike the prior one. And it focused more broadly on how the healthcare system can be reinvented to foster innovation and improve delivery of care. It had 6 specific aims for improvement, which have some overlap, but are very specific as to what they're aimed to do. Safety, effectiveness, patient-centeredness, timeliness, efficiency, and equity. And so we'll define each one of them and talk about how they apply to radiology briefly. Safety is care that is intended to help avoid injuries to the patient and is free from error or free from harm. So in radiology, you might think about how much radiation dose we're exposing our patients to. Are we exposing them to more radiation than we need for appropriate images or to make our diagnosis? You could also think about contrast material reactions. contrast extravasations? Do you have guidelines for catheter gauges or catheter location as far as placement? You can think about patient falls, hand washing, procedure timeouts with ID verification, and in places like IR where you do procedures, you can look at complications like, for example, central line associated bloodstream infections. Effectiveness is a second aim, and it basically means that care should be based on scientific knowledge, and we should be using evidence-based medicine. With this basis, you want to provide that care to all that would benefit from it, but none that would not. In radiology, if we're talking about evidence-based, you might want to measure the outcomes of your procedures or the appropriateness for your imaging studies. Are you using appropriateness criteria or some other evidence-based method? Positive predictive rates and radiologist performance, for example, as you may see in a departmental peer review system. Patient-centeredness is the third aim. It basically means that services are provided that are respectful of and they're responsive to the individual patient preferences, their needs, and their values. So patient values here should be guiding our clinical decisions. And so how do we address patient needs in radiology? Well, for one, patients would like to know their results. Do we communicate with them? Do we talk to them? Do we tell them what those results mean? Do you have a patient portal in your department where the patient can reach their reports? How about follow-ups? With follow-ups, do you just leave it up to the ordering physician to do the follow-up, or do you make sure that the patient obtains the proper follow-up? Do you have a system to do so? You also want to look at patient satisfaction, and on the subject of satisfaction, also think about your ordering physician satisfaction, because your patient is the ultimate customer, but really our ordering physicians are our most immediate customer, and so you want to make sure they're both satisfied with the services. On the other side of that is, do you have a way to handle customer complaints and how to address them? Timeliness is the fourth aim, and it basically means that wait times and harmful delays should be reduced. I think that's the one that we're the most familiar with in radiology. We're all familiar with having to finalize our reports quickly, report turnaround time, but there's also turnaround time with IR, with patient wait times, times to next available appointment, and general patient throughput. Efficiency means that waste is avoided. It includes waste of equipment, supplies, ideas, and energy. And so if we're running an efficiency radiology department, you want to reduce unnecessary studies. For example, if you're getting daily ICU chest radiographs, do you really need them? Do they really hamper your workflow? How about the number of technologies that you're using for a scanner? Do you run a scanner with 2 technologies, 1.5, so that you have 3 scanners running with 2 technologies? Scanner utilization is also an efficiency metric. So you want to see, are you using a scanner only 8 to 5, or are you able to use it 24 hours a day? Equipment downtime is another thing you want to measure in efficiency. So during the times that you actually should be scanning, how often is the scanner really available? And then associated with that is scanner room turnaround time. So between one patient and the next, how long does it take to get from the first patient to the next while you're not really scanning them? The last aim is equity. Equity means that care does not vary in quality because of personal characteristics such as gender, ethnicity, geographic location, or socioeconomic status. And so in radiology, you might think about how our different modalities reach across the community. So for example, if you had a stroke in the middle of the medical center, you may have an MRI quite quickly, whereas if you have a stroke anywhere else, it may take some time, or you may not have an MRI at all. So another way to see quality in radiology is to use what is called in a JACR 2006 article the quality map. And this quality map basically tracks the patient as they go through the department during their care. And so when you start, first you have to have an appropriate exam. And so you want to measure, are you using appropriateness criteria? Are you doing unnecessary exams or incorrect exam orders? Are you using contrast properly? Are you prioritizing the exam properly, as unlike many times where stat exams are used, are ordered when they're really not stats. And so things that can help you with that would be something like decision support software. The challenge here is to have customer buy-in. Then once you decide what exam you're doing, you have to schedule the patient. And so here you enter into waiting times. And waiting times can be a problem. For example, in complex modalities like MRI, you may have competing populations such as outpatient, inpatient, patients that need general anesthesia, and then ED or emergent cases that need to be squeezed in. And so you need many people to work to have a smooth MR patient throughput. Once Once the patient is in your department, then you want to have a standard protocol, a protocol that is uniform and evidence-based. And this presents its own challenges because we sometimes don't get the appropriate exams orders, we don't have proper histories, or there may be a lack of compliance. Subsequently, once the patient has had their exam and is leaving the department, you want to ensure their experience is a good one. We measure patient satisfaction with Press Ganey, HCAHPS, and other surveys. However, surveys really are not the best way to gather this data. What I would recommend for people that have that is you kind of keep tabs on the comment section. The numbers are important, but the comment section is what's going to help you really know what's going on with your patients. Once you're interpreting the exams, you might want to think about using something like structured reports or reports that are uniform. There's many different evidence-based reporting guidelines out there, BI-RADS, LI-RADS, PI-RADS. There's recommendations for thyroid nodules, carotid ultrasound, and all kinds of ACR white papers that can help you guide you through reporting, and so that it can be uniform throughout the department. And then comes the finalization of the exam. Like I mentioned before, there's a lot of pressure for us to have our reports done in a timely manner and finalized in a timely manner. So then you gotta wonder, do you have an evening shift or a night shift, or you prioritize stat exams? Do you have a method of communicating exams efficiently to physicians even if they're not finalized? And then finally, you want to look at your global outcomes. And so have a good relationship with pathology, with your other clinicians, have M&M conferences, radiology rounds, and tumor boards, and also internally have a robust peer review system. And so finally, I just want to say that hopefully this gives you a basic understanding of radiology quality improvement and a framework to begin your own work as a professional. Thank you.